Good afternoon, everyone. If you could please mute your microphones as you come in. We are just admitting folks and we will get started in just a couple minutes. So it is 1:01 p.m. I will go ahead and get things started. Just first, a couple housekeeping items. I wanted to say thank you all. Well, firstly, my name is Sydney Carter. I'm the Program and Policy Coordinator for NBHP, and thank you so much for your attendance today. Please stay on for the duration of the entire presentation if you would like to be eligible for 1.0 CEU credit. You must join the presentation by 1:15 p.m. to be eligible for the credit, and the eligible categories for CEUs are LMFTs, LPCs, and licensed social workers. And please complete the survey that will be placed in the chat at the end of the presentation to be eligible for the CEUs. And that information is in the chat of this meeting as well. And I would like to introduce our wonderful speaker today, Dr. Sophia Banu of Baylor College of Medicine. She is going to be speaking with us today about advocating for refugees, a psychiatrist's journey with refugees. And NBHP is also proud to be a United Way funded partner. So again, thank you so much for being here, and I will pass it over to Dr. Banu. Thank you.
Thank you so much, Sydney, and thank you for inviting me to talk about my passion about refugees. So should we just get started?
Yes.
Awesome. So thank you again all for joining me today as I take you on my journey from the roof of the world to the 4th largest city in the United States. And I have the privilege of sharing incredible stories of amazing human beings who are my teachers as I read my life experiences around the strength and compassion they possess. So let's start the journey. All right, so just some objectives. I think you already have that on your CEU list, to demonstrate a basic understanding about the qualification of refugee status and the process of resettlement, to identify common mental health problems, myths and misconceptions about refugees, the importance of understanding cultural humility and cultural competency, and last but not the least, how to foster relationships with refugee communities, support services, and local businesses while we work with the refugees. So moving forward, I would like to ask a question to my audience. Who here is a refugee? And Sydney can help me check the answers. Who here is a refugee? Who here is a child of a refugee? Who here has a relative who's a refugee? Who here has worked with a refugee? Or who here knows a refugee? Just by a show of hands.
Yes, please raise your hand on the reactions or put in the chat. So far there's 3 hands raised and 4, 5, there's a lot more coming in.
Awesome. So 8, I see 8, 10.
Yes, and there's some notes in the chat. Tracy and Aleida have worked with refugees, and Tracy knows a refugee.
Okay. Awesome. So if you have not raised your hands, and I'm assuming the fact that you're attending this presentation is you'll probably be in contact with a refugee in the near future. Okay. So very briefly, I wanted to share my story, which, like I said earlier, begins at the roof of the world, Tibet, when my parents and grandparents were forced to leave their country and settle in a country that was completely different, new language, new climate, new culture. And so, you know, they struggled a lot. But my work with refugees and survivors of torture started in Nepal at the Center for Victims of Torture. I was on vacation and had gone to meet some family members, on a vacation. I met a friend of mine who was a social worker, and she was working for this Center for Victims of Torture in Nepal. And she told me that, if you join us, it'd be great because we have a lot of women who've been raped and tortured, but they refused to go see a doctor because most of them were males, and culture and tradition played a great part in their lives. So what I did was I met her boss the next day, and I was offered a job right there and then. But I wasn't a psychiatrist at that time. I was, just completed medical school and had done brief internships in surgery and pediatrics. Hadn't quite decided what I wanted to do. So I took the job. And so basically I was treating common medical ailments, some OBGYN issues, and also, documenting torture cases for Amnesty International. So my job then took me to New York, where I had to present to the State Department. And while I was in New York, I decided, I want to do psychiatry because of my exposure to the survivors of torture. And I did my residency. And then in New York, I joined the Bellevue NYU program for survivors of torture, first as a volunteer, then as a fellow. I did a psychosomatic fellowship at NYU, and then followed by, I joined them as faculty. And then, my road brought me to Houston, where initially I would, I missed New York so much that I would fly to New York every 2 weeks, see my patients, and then come back and take care of my child and the home here. Of course, that didn't last too long. So I decided then I should apply for a job here at Baylor. And then when Baylor hired me, I told them that I wanted to start a clinic for refugees and survivors of torture. And that's how the Clinic for International Trauma Survivors started, where I trained residents and medical students. And then in 2017, I worked with the Alliance, which is one of the resettlement agencies here, to start the Alliance Wellness Center. So now I am at Alliance 2 days of the week, seeing refugees, survivors of torture, and also the underserved population. So one of the first cases that really, really had a huge impact on my life is this of this young Buddhist nun that I saw and treated at the transit center at Banu. She was a young nun who had been arrested and tortured for taking part in a peaceful demonstration, and so while I was tending to her injuries, that she had endured while she walked through the mountains, and also then documenting what had happened to her while she was imprisoned, I was becoming really angry, at what had happened to her. And I was like, I couldn't contain myself. And I said, gosh, you must be so angry at the perpetrators, for what they did to you. And her answer completely blew me away when she said, no, I'm not angry at them. She said, I feel sorry for them, that they had such bad karma, that they were born to do such evil things. I will pray for them, she said. I will pray that in their next lives, they are reborn as better human beings. And so you can imagine, hearing something like this, how can it not take over your life? So when I have friends and family members and colleagues ask me, how can you work with survivors of torture who've been through horrific torture, or refugees who've been through horrific trauma? I always say, like, stories like this of this young Buddhist nun who had so much compassion for the perpetrator. She wasn't worried about herself. She was, meditating, praying, but she was worried about the perpetrator. Where would I hear a story like this? And I always say, how can I walk away from such compassion? How can I not develop a passion for working with refugees and survivors of torture? It's hard to believe, but these stories that I'm going to be sharing with you are being lived by these amazing human beings who teach you about life and struggles every day and every time you meet with them. So just to get some of the definitions and some of the statistics out of the way, which is really important, the statistics are really important, I just wanted to share with you that the United Nations High Commission for Refugees was started in 1951 by the United Nations General Assembly to assist the refugees of the Second World War. And at that time, they also defined the definition, who a refugee is, and the type of legal and social protection a person was entitled to from a host country. And they make a stark distinction between an immigrant and an economic immigrant. I mean, between a refugee and an economic immigrant. If you guys know the definition of all this, I'm just going to move forward. Just let me know by show of hands. It's quite simple. The only thing that I would like you to keep in mind is do not intermix immigrant with refugee, because there are people who will take, they won't like it if you call them an immigrant, if they're actually a refugee, and if they're a refugee and call them the other way around. Because the main difference between an immigrant and a refugee is forced to flee, where an immigrant assumes permanent residence in a country other than his or her original homeland. So that's the main difference. And of course, the other difference is that most of the refugees cannot return back to their home country because of a fear of persecution. And it could be based on just belonging to a social group or a membership, religion, nationality, race, of course, all of that also comes into play. The other definition that I really want to make sure the audience understands is the difference between an asylum seeker, an internally displaced person, and a stateless person. Do you guys know the definition, or do you want me to read it out? And you can unmute yourselves if you want to answer.
Read it. I don't know it.
Okay. So asylum seekers are somebody who seeks international protection and whose claims for refugee status have not yet been determined. It depends on the judge who gets the case. And so once an asylum seeker gets asylum, they're called asylees, and they get all the benefits that a refugee gets. An internally displaced person is somebody who has not crossed an international border, and somebody who has been forced to flee, like for instance, during Katrina, a lot of people from New Orleans moved to Texas and to Houston and Dallas and Austin. And so they were internally displaced. They were still within their country, the boundaries of the country, but they moved from one city to another city. So that's the internally displaced person. Stateless persons. Does anybody know of any stateless persons or a group of stateless people around the world?
About the ones who are in Guantanamo Bay and nobody wants to take them back?
That's a really good comment. I wasn't even thinking about that. But they do belong to a certain country. Maybe the country doesn't want them back, but they do belong to a country, right?
Unless they are stripped of their citizenship.
If they've stripped of the citizenship, yes, that would be a stateless person. Absolutely. And I thank you for pointing that out. I have never even thought about that. Any group of people, have you heard of the Rohingya refugees?
Rohingya refugees.
Rohingya, yeah.
Yes.
Yeah, so that's an example of a group of stateless people who do not possess the nationality of any state. So that's another thing to keep in mind if you come across. This is a very busy slide, I apologize, but I wanted as much information on this slide so that we can move on to the next slides. So by the end of 2021, the global trends, as per UNHCR, there were 89.3 million people displaced worldwide. And out of which most of them were internally displaced, about 25 million were refugees, and the rest were asylum seekers. And most refugees came from these 5 countries, top 5 countries. We're talking about the end of 2021, okay? So Syria, Afghanistan, Myanmar, South Sudan, and Venezuela. And the top 10 refugee hosting countries. And tell me if you guys are going to be surprised to hear this, but Turkey hosts the largest number of refugees, followed by Colombia, followed by Pakistan, and then you can see the rest, and included in there are Iran, Ethiopia, and Bangladesh. And so 80% of the world's refugees are hosted in countries that are economically disadvantaged and have a lot of conflicts ongoing within their countries. So you can imagine the burden on those countries. Regarding asylum applications and asylum and resettlement, by the end of 2021, United States was the country that accepted the largest number of single asylum claims. And so that's really good news. The other number that I wanted to point out to you is the 100 million that you see. And so early 2022 or mid 2022, the number rose from 89.3, that was at the end of 2021, to 100 million because of the Ukraine war. So the war has displaced millions of people, right? And it pushed the number to 100 million. So that's about 1% of the global population is in dire need of shelter and other resources. Only 13 countries have a bigger population than the number of forcibly displaced worldwide. So just to keep that in mind. Okay, so I want to do a quick survey with you guys. What will you take with you? If you had to leave right now, you had to flee, wherever you're sitting, there are bomb blasts outside your door, the country's being invaded, or there's a civil war going on. What will you take with you? You don't have time to think, or you don't have time to go and pack. Your lives are in danger, your children's lives are in danger. What would you take with you? And you can unmute yourself if anybody wants to share.
My IDs.
Your IDs, okay.
Some food.
He
Food?
says his IDs, but if you don't have time to get anything, literally sitting here, and if there's a bomb outside, what are you going to take? Keys and driver's license, which I don't know.
Which you have on you, right? Which you have in your pocket or something.
Phone.
Phone, okay.
I'm gonna take myself.
Self, yes, of course. You want to, be safe. So most of the clients that we see, or that we treat or that we come across, have fled in dire circumstances. And this is, I saw an article on Al Jazeera, and they had asked this question, and I thought it was really interesting because I haven't seen any other article like this. And so they asked the refugees, what will you take with you, or what did you take when you had to flee? So somebody, I think some of your audience members said that they kept their papers on themselves just in case they need to identify their body at some point. They took their phone because it had precious photos of their family. Some people, they said, one person said they took their keys of the house, they have big keys to show that as a testament that they held on until the last minute. Some people left with nothing, they just ran. And some people left with hard disks if they had time to, gather. So where do you go with this? If you were able to pick something, food, clothes, phone, your child, your pet, your car, where do you go? You would be in a refugee camp like this, makeshift refugee camp. And this was a camp that, actually, this is not one camp, this is many camps that Dr. Martina and I visited in 2017, right after the Rohingya genocide in Myanmar. And these are tents, shelters that were made by the refugees themselves by the help of the Bangladesh army. And Susan Cox is down. Sorry?
Yep.
Was that a question?
I think someone was just off mute, but they've muted themselves.
All right, no worries. So this is where you'll be languishing for months or years, or you're many years on end before a third country will say, oh yes, we want to take in 200 Rohingya refugees from Bangladesh, or 100 Syrian refugees from Turkey, or from refugees from Congo, or refugees from Ukraine. So you have to, most of them are in refugee camps like this all over the world. So this is a resettlement, how a resettlement process works. Refugees do not apply for resettlement themselves. So they're in a refugee camp and they cannot apply for resettlement themselves. It's the UNHCR that chooses who's going to be resettled. And you have to belong to these 4 vulnerable categories. people who have urgent medical needs, survivors of violence and torture, women and girls at risk, and children at risk. So you have to qualify and be in these 4 vulnerable categories in order for you to be resettled. And refugees who are going to be resettled by UNHCR cannot pick the country of resettlement. They cannot say, oh, I'm a refugee and I belong to this one of these 4 categories, and I want to go to Canada, or I want to go to Germany, or I want to go to the US. It doesn't work that way. UNHCR decides which country you're going to be resettled in. And persons who have been found to have committed serious crimes or pose a threat to others will not be referred for resettlement to another country. So just please keep that in mind. And the lower numbers of this particular slide are sort of outdated, and I already gave you the updated numbers.
Sophie.
Yeah.
Can you please repeat what you just said, what you said for us to keep in mind? I didn't hear the first part. The ones that would not be resettled.
Oh, so if they have been found to have committed serious crimes in the camp or in their country, or if they pose a threat to others in the community, they will not be referred for resettlement.
Okay, thank you.
Make sure about that, yeah. So, so let's just say, right, United States says we're going to take 100, Syrian refugees and 50 Sudanese refugees. So how does it work? UNHCR collects biographical data and biometric data, which includes the iris scan, fingerprints, facial scan for each refugee referred for resettlement. And so the US government says, okay, we're going to take, this group of people. So what do they have to do? After having gone through all of the scans, like I told you, they have to go through 8 US government agencies, 5 background checks, 6 separate security databases, and 3 in-person interviews before they're allowed to set foot on the US soil. And once a refugee has been accepted for resettlement, the State Department then assigns their case to one of the 9 US NGOs that are, their headquarters are in Washington, DC. And each NGO in Washington, DC has local offices like in Houston, in New York, in California, in Nebraska, in Minnesota. And so once they send the data, they will decide which agency is going to take them, and each agency is then going to tell, like, suppose they're coming to Houston, they're going to say, okay, Alliance will get 5 refugees from Ukraine and 5 refugees from Congo. So the case manager will then go to the airport and pick them up. That's how they come. So a refugee, I cannot imagine anybody else who is more seriously vetted than a refugee who comes to the United States. And once they are in the United States, each resettlement agency is being funded mostly by the Department of Health and Human Services through the Office of ORR. And in Texas, I think it's through the Office of Immigration and Refugee Affairs. And so each agency, like here in Houston, I don't know if everybody's from Houston or from other cities, but in Houston, we have 5 resettlement agencies. You have the Alliance, you have the Catholic Charities, Interfaith Ministries, Refugee Services of Texas, and the YMCA. So 5 of them. So each agency, provides case management services. Each agency has employment agency department where they help you to find a job. ESL classes are provided, and there are certain resources that are for each agency. For instance, only at Alliance do you have driver's education. Only at Alliance do you have a wellness center where we treat refugees and survivors of torture for free. Psychiatric evaluations, medication management, psychotherapy, group therapy, all of that. And then legal services mostly are with Catholic Charities and YMCA. And of course, then we have the preferred communities, which are for elderly refugees, refugees, unaccompanied minors. Catholic Charities, that's a huge department of unaccompanied minors that they take care of. So these are some of the things that you need to be aware of. Services that a refugee receives when they come to the US. Case management services would include health services where, and each refugee is mandated by the government to get a free health screening where they check for vaccinations. If the vaccinations are not up to date, they provide it. They do, blood test, and they provide like a head to toe physical checkup. before they are, go out into the community. Then they also do cultural adjustment services where they promote family well-being, family literacy, participation in children's schools, and other, they have an orientation course that each refugee goes through, hopefully in their own languages, about what to expect when you're in the US. I've had, refugees who came from Nepal, who were from Bhutan, who had difficulties getting on a bus because they were farmers back home and then lived in a refugee camp and then came to Houston. And so, getting on a bus was like an ordeal for them. So I had a medical student who ran these groups. One of the sessions was how to take the bus, how to get on the bus. So there are many things that we take for granted that we should be aware of when we are seeing refugees. Coming to misconceptions and myths, one of the common misconceptions are that refugees are a security risk. And according to Cato Institute, the chance of being killed by a refugee in America is 1 in 3.6 billion. And while over 3 million refugees have been, and the numbers have gone up, of course, have been admitted in the US since 1975, not a single refugee has committed a lethal terrorist attack. So just for you to know that. The other misconception is that the economic implications, they do get financial aid for the first 90 days. And they also, the money that they get, some part of the money goes to IOM, which is the International Organization of Migration, that provides the tickets, that buys the tickets for the refugees to come from the refugee camp in Sudan to Houston. So they have to pay back the ticket money to IOM. And part of the money that they get goes towards paying back for the ticket. Some families do get financial aid for longer, depending on the situation. And it's specific to each person, and depending on their circumstances. So the other thing is, according to a recent report by the Department of Human and Health Services, refugees have contributed a net of $63 billion to the economy. And refugees who enter the US between the ages of 18 and 45 pay on an average $21,000 more in taxes than they receive in benefits over a 20-year period. And the source is IRC, the International Rescue Committee. I just want to stop here briefly and ask, I know, it doesn't matter if you're famous or not, but just for fun's sake, can anybody name a famous refugee? It's like a trivia question. Any famous refugees that you know?
I wish I knew. Someone said Albert Einstein. Aisha said Albert Einstein.
Yes, absolutely. And he was a huge proponent. He was a refugee himself. And he has, I don't know if you read about him, but he has written letters, lamenting about the condition of refugees and how when he was in New Jersey, how he felt so guilty being in a house when there were hundreds of thousands of people, refugees who needed more help. You should definitely read up about him. He actually contributed, I think, a large part of his earnings that he made over, to the refugee cause. Anyone? Anybody? In the US? I can give you a hint. I'm using Google.
There's also in the chat other famous refugees. Jesus Christ, yes.
Yes.
Gloria Esteban.
Yes.
Andy Garcia.
Yes.
And Freud.
Yes. Yes, thank you for all of those. And the first female US secretary, is that right? Somebody please help me. Madeleine Albright, who just passed away.
Mm-hmm.
She was a refugee too.
Oh, yeah.
Google's co-founder was a refugee. So, you guys should look up famous refugees. But, everybody needs help. Talking about misconceptions, I wanted to share a case example with you guys. I saw a 37-year-old refugee male. He was referred to the clinic because he was on medication for his mood, history of bipolar disorder, and he'd been hospitalized inpatient back home. And he reported that he had been working with the American government, and during one of the bomb blasts, he had been injured. And wife reported that since the injury, he's had these episodes every now and then, which sounded like manic symptoms, and he was meeting textbook criteria for bipolar disorder 1. And soon after he arrived, he was hospitalized with full-blown manic symptoms, and I actually saw him in the clinic. During the hospitalization, an MRI was done, which showed an obliteration of his white matter, which is consistent with severe traumatic brain injury. And he was discharged with meds with close follow-up. So, I saw him on one of the, after the discharge, and I, told him and his wife and his case manager that he should not work right now, that he should, take time to sort of relax, settle down, and, because he was like, really wanted to go and work. Like, he was like, I have to work, I have to work, I have to work. And because he wanted to provide for his wife and his family. And so, we told him that he should not work. So when I saw him a few weeks later, for a follow-up, his wife was over the phone with an interpreter, and he told me that he was not sleeping. So I asked him what happened, and he said, I'm sad. And I was quite surprised that he said that, because he doesn't speak much and he doesn't talk about his feelings. But I was happy that he was able to verbalize his feelings. And so I proceeded to ask him, why are you sad? What made you sad? And he said, you tell me no work. I have no money to pay rent, bills. I want to work. Let me work. In his, he knew a little bit of English. So for a moment I was speechless, and I didn't know how to respond, because the irony of the situation was not lost on me. Some of the days I spent in my regular clinic trying to convince my patients to work, why it would be good for them, and and they don't want to work for whatever reasons, And here I have a refugee who I am telling not to work, but he's insisting he wants to work so that he can pay his bills. So at the end of that session, after talking to his wife and his case manager, we told him, okay, you can work part-time, and in the meantime, the case manager, we asked the case manager to apply to appeal for his disability. They'd applied for disability for him because, like I said, the MRI showed complete obliteration of his white matter, and his symptoms were consistent with TBI, even though he had textbook symptoms of bipolar 1 disorder. So he was all smiles when he left the clinic. So I can tell you, in my years and years of working with refugees, I probably have about 5 or 10 refugees at the most on disability. That also, we sort of tell them, no, you have to apply for disability. So I want you to keep that in mind. The other thing that I really want to hone in on is 1 in every 2 refugees is a child. So we have an entire generation of children who have not had a normal childhood, who have lost their childhood, basically, who are grown up or born in refugee camps, grown up in refugee camps. So if you do see an adult refugee in your clinic, make sure you ask them about their childhood, because it's really important that you do that so that you can address issues that come up. So just want to share some pictures with you. And if you've ever visited refugee camps anywhere in the world, you will be surrounded by children. This was in Greece, and this was in Cox's Bazar and Bangladesh. Everywhere we went, we were surrounded by children. Keep in mind that a child or even an adult's refugee experiences pre-migration experience, transmigration, and then post-migration. Just because they've finally come to the US doesn't mean that everything is fine. So another case that I wanted to share with you, it is very important to view children's experiences in terms of their life histories, because of the accumulation of traumatic events that take place in a child's life that can predispose them to psychopathology. So this was a young 16-year-old boy from Bhutan, a refugee kid from Bhutan, who was seen in my clinic after he had attempted suicide. He had tried to hang himself, and saw him in the clinic for a psychiatric evaluation. And just talking to him, I found out that he had been born in a refugee camp. He was about 12 years old when he came to the US with his family, and his family members, his parents were farmers back home, And so they didn't speak any English. And he had attended some school in the refugee camp in Nepal. So he knew a little bit of English. So every time the door rang, every time they went to the grocery store, every time the phone rang, it would be him. They would say, oh, here, talk to him. Oh, here, talk to him. Oh, here, talk to him. If they went to a doctor, here, talk to him. He will tell you. So the roles were reversed, the parents became the child and the child became the parent. Thankfully, in school, he had some friends who were from the same country. They live, I don't know if you know this, but in Houston, most of the refugees are settled in apartment complexes where there are other refugees from the same country. So they went to a same school, all of the families in that neighborhood. And so when he was in school, these older, students would help him. So he wasn't being bullied or anything. They would help him with his schoolwork, and they would just hang out. But then they were senior, and they sort of graduated and went to college or went to work. So he was alone in the school, and so school work became really difficult for him. And then on top of that, he had all these responsibilities of taking care of his house and his family members. So he said he got so depressed that he just wanted to die. And so after the evaluation, I usually ask the children that I see in my clinic, if you have 3 wishes, what would you wish for? And he just looked at me and he said, I just want to turn 18. And so I can go back to the refugee camp that I grew up in. I don't want to be here. So that was really hard to hear, that. So keep in mind, when you use a child for interpretation, keep in mind that a child's trauma is it's like accumulating. So just keep that in mind. So there are lots of, actually not too many papers, but this paper is really, I found it very helpful in 2013. A lot of boys, as expected, I think, externalizing problems, oppositional, aggressive, impulsive, hyperactive, antisocial behaviors. Girls were more internalizing symptoms. And many did not meet criteria for PTSD. You know how we are very gung-ho here about, oh, did they meet criteria for PTSD? Do they meet criteria for MDD or GAD? They found out that they didn't meet criteria for PTSD. It was more of symptoms of PTSD, symptoms of major depression that they presented with. And that doesn't mean that they're not suffering. So if you just because they don't meet criteria doesn't mean that whatever happened to them did not happen. Just keep that in mind. So I want to share another case with you guys. This was a 14-year-old boy from El Salvador who had come alone with a coyote to the US to join his mother and her new family. And the presenting problems were that he had been diagnosed with ADHD and he was on medication, but he was not improving. And so by chance, the mother had found out about our clinic. And so we saw him, my resident and I, and we have the luxury of spending an hour and a half with the child. We went to ask about pre-migration, transmigration, and post-migration. So for this child, pre-migration, since he had been left home with his grandparents were very abusive. They would hit him all the time. And he grew up in a gang-infested neighborhood where one of his best friends had been kidnapped, and they were asking for ransom to his best friend's family members, and they couldn't afford to, and the gang members had sent his finger to the family with which the child saw. And then finally, when the mother was able to collect enough money and pay a coyote to bring him, we asked him about like what his journey was, like what did he witness, how was it, like having a conversation basically. And he said he saw many people being beaten, he saw a dead body, and then he said very quietly, he said, and there's something that happened to me that I will never tell anyone. And I can imagine, and of course we didn't ask him, no, you have to say, and we just said, okay, whenever he's comfortable, he'll tell us. So when he came to the US, right, his mom had a new family and he had, half siblings. And so, and he went to a school where they were taught in Spanish and English, but his English was not very good. And so he would get teased in school. And then they would tease, so he had, he was externalizing his emotions and he was acting out. And so the mother took him to see a pediatrician and then a psychiatrist, and they diagnosed him with ADHD. He had symptoms of ADHD. And And then so because he was on medication, his half siblings would tease him at home and say, oh, you're the crazy one. You're the one who takes medication. So not only did he not get any relief at home, he was being bullied at home also by his half siblings. And so, so when we sat down and we found out that he actually had PTSD. So if you see a child, a refugee child who's been diagnosed with ADHD and doesn't get better with medications, or you feel like he needs an additional evaluation, please ask about pre-migration, trans-migration, and post-migration experiences. Doesn't have to be trauma, it can just be experiences that can actually, so he had PTSD symptoms that look like ADHD. And I'm not saying somebody was wrong and diagnosed. If you saw him and if you had the symptoms on the paper without an evaluation that included in-depth, questioning or time that we spent with him. So we referred him for trauma-focused CBT, took care of his medications, put him on an SSRI, and move forward from there. So just for you guys to keep that in mind. Again, one thing that they found from this paper is post-migration factors in high-income countries like the US, including family cohesion, social support, and positive school experiences, have been shown to confer a protective effect against symptoms. So all of these together, help the child not develop mental health issues as they grow. Now, coming to one of the most important parts, cultural factors. Cultural factors needs to be addressed and understood by providers. And sometimes, there are refugees from different parts of the world who do not have a word to describe what they're feeling, like an English word to describe what they're feeling. They do not have it in their vocabulary. They may have cultural understanding of their distress that do not meet the criteria in our diagnostic paradigm. And like I said earlier, not everyone has to meet PTSD or MBD, but they still need help. They still have symptoms and they still need help. And remember, the other thing it could be just prolonged grief, yearning, avoidance, disbelief, or just feelings of emptiness. Oh, and I'm running out of time. I better hurry up. Okay, this slide we have to read. I'm gonna. I think Sydney asked me to send the slides, so I will send the slides. But anybody can be culturally competent. Please keep that in mind. You can watch a documentary, you can read a book on cultural competency, but cultural humility is something that you will learn from the person who's sitting in front of you, your client. So no matter what you read, no matter what you know about the country, about the village, about where they come from, nobody can teach you more about their culture than the person who's sitting in front of you. So that's cultural humility. It's a lifelong process of self-reflection and self-critique, whereby the individual not only learns about another's culture, but one starts with an examination of his or her own beliefs and cultural identities and biases, and become aware of how culture can affect health behaviors. So I want to really share some examples of case examples. I saw this young Haitian male in New York at the Bellevue program for NYU survivors of torture. He was a single Haitian male who was imprisoned and tortured in his late teens because of his father's political affiliations. And when he was released from prison, his whole family had disappeared. And he came to us presenting with some anxiety symptoms. And I had an interpreter, a French interpreter, in the clinic, and he denied all symptoms. He was going to school and he was working, and he said everything was fine. But it didn't sit right with me, and I thought there's something wrong with this picture. So I, by chance, met another interpreter who was from Haiti. And I just, described this case to her, and I said, there's something wrong with this case. And she was not surprised when I told her that he had denied every symptom, just some anxiety symptoms he had. And she told me, can you please bring him back? And I will be your interpreter. So I said, okay. So we brought him back. Oh, and then what she told me was, me being a female provider and him being a young guy, he will never admit to a female person that he is suffering, because that goes against his traditional upbringing of, oh, men, boys and men don't cry, or they don't
Macho.
that they are sad, that they are suffering. They will not say that. So when she did the session with me, she reassured him that I would not, or she would not think, both of us will not think, low of him, or he would like, like we wouldn't be upset, or we won't think that he is not strong enough or he's not mature enough if he tells us how he's really feeling. And of course, lo and behold, he had symptoms of PTSD and MDD, and we started him on medication and therapy. He hadn't been sleeping for days on end because he was working, he was, studying. So make sure that even if you have an interpreter, it's an interpreter that actually knows the culture. I'm going to skip this for time. Another case example that happened to us recently, about a year and a half ago, 35-year-old female from Central Africa was referred for psych evaluation. She had endured horrific trauma where her family members were killed, and she was herself assaulted and left for dead. And so she reported that she was feeling really lonely here, that she didn't have a church to go to, as she lived very far from town. She missed her hometown, did not know anyone here. And so, in my clinic, I have residents who do the training with me. And so he found through, local communities, found a pastor from her hometown who, had a church and was, helping people, from their community. And so we were really happy. We were like, oh my God, this is amazing. So when she came for one of her sessions, we gave her the name, that we had the name of the person, first name, last name, and the phone number, and we gave it to her. And and then we progressed with the session. And then towards the end of the session, I just said, oh, yeah, you must be really happy that that you're going to finally connect with somebody, and hopefully you'll be able to attend the services and make friends. And she just looked at us, me and my resident, and she took out the piece of paper that she put in her bag. And she said, I will not call this man. I will not call this person. And we're like, why? Why not? And she is like, well, the last name of this person indicates that he was from the tribe that killed my family. And she was in tears, and we were like, oh my God, like, what did we do? We didn't know. We thought, oh my God, same hometown, So this is what I mean about cultural humility. If that person sitting in front of me didn't tell me that the last name indicated that the tribe that killed her family, not that that gentleman had anything to do with, the killing, but for her, it was the tribe, So cultural humility, please keep in mind that your best teacher is the person who's sitting in front of you. Another thing to keep in mind is when you work with refugees, 44% of refugees and asylum seekers have experienced torture. So please make sure you ask about torture. If there's any scar on their face, on their hands, or any part of the body, if you see, make sure you ask. And if they're touching the scar, they subconsciously want you to ask. So make sure you ask, do not hesitate. Want to show you this picture. Everything is wrong with this picture, but tell me what stands out. And I'm sorry, I'm rushing because I'm looking at the time. I have only 10 minutes. Anybody?
It appears that there's a doctor there who's supposed to be
gonna say
helping,
the
but
same.
he's participating in the.
He's helping?
One guy is not looking, Amy says.
So you're
Megan said he's being dunked in a Coca-Cola vat. Noah said the guy at the stairs is looking out for anyone coming.
okay.
Is that doctor checking a pulse?
Why? Why is he checking his pulse?
Just to make sure that he's not dead, so the
Yes.
torture can continue.
Yes, absolutely, yes. Everything's wrong with this picture, I don't think it's Coca-Cola, it just says cola. I just want to make sure I don't want to, be accused of being something against Coca-Cola, but it just says cola. So, but, yes, the doctor is there checking the pulse to make sure, because the aim of the torture is not to kill. The aim of the torture is to make them suffer, so they tell you what you want to hear. And it's been known that torture does not reveal anything that is the truth. Torture reveals what you want to know. what you want them to reveal. So please keep that in mind. And so if there is a person who comes to see you in the clinic, and if you have a doctor who's wearing a white coat, they may have a reaction to that doctor. They may not come back. The first time they may be there, but they may not come back. You must also know that there are therapists and psychologists and psychiatrists who take part in creating a manuscript for how to torture, how to break down a person. So if there is a negative, transference or counter-transference towards the therapist, please keep in mind that it may be the reason that they may have taken part in the torture themselves. Again, very, very important, you should attempt to relate to the suffering in the context of the individual's beliefs and cultural norms, an attitude of informed learning rather than to rush to diagnose and clarify. Is this the Istanbul Protocol? Keep that in mind. If there are variability in presentation, if one day they say, this is what happened to me, and next one they come and say something different, doesn't mean that they're lying. They may not remember PTSD. You can have memory problems. They may have problems recounting, what happened to them or the way the events happened to them. And so just keep that in mind also. Sexual abuse is common amongst torture practices, and this influences the exam. So as much as possible, have same-sex interviewing possible. Male survivors are very reluctant to disclose sexual abuse, but you should definitely ask them. Listening is more important than asking questions. Please remember that open-ended questions are important, closed-ended questions are important. No matter how you ask them, ask questions, do not hesitate. I have this case of a 35-year-old Liberian female who used to be a vegetable vendor, and very, very loud, and would, talk about politics and what is wrong with the government, and, in the village, in the marketplace selling vegetables. And she was arrested and, tortured by rebels and shot at, and she had gunshot wounds. And I used to see her at NYU for therapy and medication management. And, so I would ask her, so how are you? What happened? What did you do last week? And she would say, oh, I was fasting and I did this and I did that. And I was like thinking, oh, it's not Ramadan, it's not Lent, it's not Yom Kippur. Why is she fasting, So I just decided to ask her instead of just going on to the next question. So I asked her, why are you fasting? Every time I ask you, what did you do? You tell me you were fasting. And then she told me that, every time I try to eat, my food gets stuck here because I don't know whether my children are alive or not, or if they have any food to eat, or if they are starving. So she was feeling guilty eating food because she was worried about her children, who she didn't know whether they were alive or not. And so I had to, immediately, of course, we were both in tears, and I had to tell her, like, if she continued fasting like this, then we would have to hospitalize her because of, albumin and electrolyte imbalance and all of that. And she hated the hospital. So, we had to, sort of regroup with her about the importance of eating, and, and then therapy continued. And, so asking, if I hadn't asked that question, I would never have known why she was fasting or why her food was getting stuck in her throat. Empowerment of crucial importance for people who've lost their sense of safety, their sense of trust. Provide a safe and comfortable location if possible, a climate where people can open up and share. If you have to go outside to the waiting room and say hi in their language, even if you, I don't expect anybody to be, an expert in somebody else's culture or language. But if you know that you're going to get somebody from Sudan, or if you know so you're going to get somebody from Ukraine, or Congo or Guatemala, if you can learn a phrase, just say how to say hi. You go out into the waiting room and you say hi in their language, and you will immediately see the way they smile. And they're already anxious to begin with. They don't know what to expect. Maybe they've never seen a behavioral health provider or a psychiatrist before, but just the anxiety level will come down. You will see that. Introducing yourself to them in the waiting room, explaining what the process is going to be like when they come to see you. Please keep in mind that there are many environmental barriers, and I don't know if I have time. It's 1:54. Maybe I should just move on. If I have time, I'll come back to the cases. At the end of the interview, please ask them if there's anything else they want to share with you. Acknowledge their difficulty. Explain the process. This one, I'm sure you all know this, right? You're all behavioral health therapists and mental health providers, countertransference, all of this can happen to you. So make sure you have a mentor, you make sure you have peer supervision. And I want to end on this resilience. You know, children affected by war display resilience, you know, and adults. There are 1/3 of the people who go through torture, who go through horrific trauma, they actually get better. 1/3 stay the same and 1/3 get worse. So I'm talking about the 1/3 that gets better. It's called post-traumatic growth. And I don't know if you've experienced this in your practice. We talk about the hope, religiosity, social support. You know, it's not that they do not acknowledge what happened to them. They do acknowledge the severity of the traumatic experience, but they have regrouped and refocused their energy into 5 domains, where there's a positive change in 5 domains. They have a greater appreciation for life. They have more meaningful interpersonal relationships. They recognize their personal strength, and their life priorities change, and there's a spiritual and existential development. And this is what I see in most of my clients who, you know, I mean, I'm not saying they don't need help. They do need help. They do need treatment. They do need therapy. They do need medication. But you will see that most of them get better and move on with their lives. Listen to them closely. Please encourage consistency. Behave in a nurturing and compassionate manner, which I'm sure you guys all do. Don't make them feel different. Don't tell them, don't think about it. Don't tell them, oh, don't talk about it. Don't tell them not to forget about it, because that's not possible. So very quickly, I want to share this case with you of this Tibetan gentleman that I saw in New York, again at the Bellevue and Envy Program for Survivors of Torture. You know, he had been imprisoned, tortured, and severely tortured with electric prods. He told me when I was doing the evaluation that he had PTSD symptoms, and in the past, but now that he was in America, he felt like safe. He didn't have them anymore, so we decided, okay, you know, he's going to come and see me for therapy since I spoke the language. So we're going to see him every 2 weeks. And then a week or so later, I saw, and I was outside the UN taking part in a demonstration. I saw my patient had, was taking part in a mock prison trial where they had put bandages around his head with red paint, and hands were in shackles, his feet were in shackles with another person behind him. Like, it was a mock prison scene, you know, and I saw him from from where I was standing, and I thought, oh my God, this is terrible. This is going to make his PTSD symptoms come back. This is going to be a trigger for him. I have to make sure that I see him soon, and so, they were walking down the street and people were taking pictures, and there were TV stations and all of that. And so when I saw him next time, I told him, I said, I saw you taking part in the demonstration, and I was really worried about you. It must have been terrible for you to do that, because I'm sure now you have all the PTSD symptoms, you know how we talk about triggers. And he just looked at me and he said, no, actually, I feel great. And I was like, what? He's like, yeah, because for me to do this, knowing that in my mind that I'm helping my people back home, because people were, taking pictures and sending it out, it was in the news, that it empowered him. That forget about having relapse of symptoms, he was feeling even better, because he felt he was helping his fellow human beings back home by, having done that, and it was out in the news and all that, so that people would know about the situation in his home country. So instead of feeling worse, it actually made a huge difference. It empowered him. So I can't stress to you the importance of empowering somebody, to help them move on with their lives. Again, I have to talk about this because this is in one of the objectives. Capacity building in your backyard. There are lots and lots of things you guys can do if you're interested in working with refugees. I train psychiatry residents, child psychiatry fellows, medical students. We have health fairs, annual health fairs, which we had to stop because of the COVID, but now we're starting back again. Our next annual health fair is in November. We have wellness education classes. We also combined with PHR, Physicians for Human Rights. We have an human rights and asylum clinic. We have training for forensic evaluation training. If you guys are interested, we have the next one in November. I would really urge you to sign up. You will be trained on how to do forensic evaluations for people who are waiting, to get asylum in this country. We have our annual refugee mental health conference, which we started in 2018. All right, what else? We started the Global Mental Health Division in the Department of Psychiatry at Baylor, workshops, the Human Rights Clinic. These are the things. These are some of the pictures I want to share with you. The health fairs, the conference, and then these are the trainings that we did in Bangladesh with Dr. Mateen and myself. And then last but not the least, when COVID-19 struck the world in March of 2020, we started doing food deliveries for refugees who did not have a car, who could not get to a food bank, single mothers, elderly refugees who had no transportation. We started delivering non-perishable food items, working with medical students and high school students. My son has a Students for Refugees club in his high school, and I would have the students come and join us, and they have a blast. When everything was shut down, we would be delivering food outside. Remember, these are the goals of treatment. No matter what kind of therapy you do, and I can't stress, no matter what CBT, DBT, ACT, I don't know, whatever, EMDR, any kind of therapy you do is helpful, right? That will be helpful. But remember that the relationship that you have with them is the main therapeutic healing tool. And so keep that in mind. You can do any kind of therapy, but the relationship that you have with that person is what will help to restore dignity and value, to restore purpose and meaning to life. And I wanted to quickly share this with you, if it's possible. You guys bear with me.
Banu, here's our organized clothing drive. So we have pants here, men's pants, women's pants. We tried to organize them by style and color. And then men's clothes, more businessy, women's/men's clothes for the older generation. And then we have like the younger women's clothes here, and extra hangers in that pineapple bag. Shoes, purses, sweaters. I'm gonna get you more storage for this later. More shoes. These are just normal t-shirts organized to size. And these are polos.
Okay.
No problem.
So I wanted to share this with you too, when we talk about providing dignity, so when a client comes to our office for treatment, besides getting a prescription or no prescription or just therapy, we ask them to go into this room and pick whatever they want. So it's almost like they're shopping, but everything is free, of course, and these are all donated items. Instead of having a pile of clothes in a corner and say, oh, you can take whatever you want, if they're all neatly arranged and it looks like you're in a store, you are giving them, you are giving dignity, you are empowering them, and you can see how helpful that is for a refugee who's lost everything. And instead of, like I said, from a pile of clothes that have been donated or shoes, if it's all neatly arranged, it makes them feel good too. And I can't, I'm sure the therapy we do is important. I'm sure the medication I prescribe is important, but I think what they feel in that room, getting a nice dress, shirt, pant, I think that's what makes them feel better, in my opinion, and I may be wrong. Okay, in summary, I guess I don't need to do summary, but please practice cultural humility. Your best teacher is the person who's sitting in front of you. Pay attention to different factors in their lives. Don't forget pre, trans, post-migration. And then the last one, I know my friend is going to be unhappy if I don't say this, but if you want to be happy, practice compassion.
And Millicent,
If you want others to be happy, please practice compassion. So either way, you are a winner. Thank you so much. And I'm sorry, I was rushing through. I have so many cases, but we have only 1 hour.
No, it's okay. Thank you so much. There are tons of thank yous coming through the chat, and thank you all so much. I wanted to say we are a few minutes over, so if you're wanting to get the 1 hour credit of CEU, please feel free to drop off. I will ask Dr. Banu the questions in the chat right now, so if you want to stay for that, please feel free to. I just put the link in the chat for the evaluation, and I'll just do it again right now. If you click that and take that link, you will be eligible for CEUs as long as you joined this presentation by 1:15 p.m. and stayed on for the entirety. And again, those eligible classes are LMFTs, LPCs, and licensed social workers. And please complete that survey by 12 p.m. tomorrow to be eligible. Try to keep it moving fast so we can prepare for our next event. So if you could complete it by 12 p.m. tomorrow, I would really appreciate it. And so now I will just go through the Q&A. If you would like to stay on, please do. And thank you all so much. If not, we will see you next time. So the questions in the
Sydney.
chat. Yes.
Are you going to send the slides to everyone?
Yes. The
Okay.
slides
Okay.
and the slides and the recording will go to everyone. It'll also be
Okay.
on our YouTube channel.
Okay, great. Thank you.
Yes, you're welcome.
Bye-bye.
Bye. So early on, Marissa said CVT is a wonderful organization, so that is great. And then there was a question, why do the countries force an individual to force out or leave their country?
Oh, you mean if there is a civil war, if there is conflict going on, it's not that the country is forcing them. They're being forced to leave because their lives are in danger. You know, they will get killed or the family members will get killed. And this is what happens usually in some countries where there's ethnic cleansing going on. You know, they will, prison all the male members, torture them, and then send them out into the community. So what does the man do? You know, they'll pick up the family and then run away because they're worried that the next time they come, they may not be alive, or next time they come, they may harm the women of the family. So that's how ethnic cleansing happens, and this happened in many countries that I have worked with.
Okay. Thank you for that. And so there was a conversation between Chandria, I think she joined or she hopped off, and Aisha about NGO, but I think they discussed that already. So if not, please let me know. But then there was a question from Francis, what do we call those who are at the borders waiting to enter or enter illegally? These commit a lot of crimes, question mark, is the phrasing.
So, you know, there is a lot of conversation going on, and there's because I've seen it when I read articles or documentaries, everybody is lumped under the term migrants, so under this whole number of people who are waiting at the border, there could be people who are from Central America, there could be people from Asia, there could be people from just across the border, and committing crimes. We are not police officers, right? If they are seeking asylum, and if the government, whichever border they're at, if the government allows them in, then it's the government's duty to vet them. But you cannot, stop somebody because you think that they may have committed crimes. But of course, like in the case of if you're in the refugee camp, there are the camp police officers, or UNHCR has safety police officers, or the country itself has officers in the camps, to monitor people who are going in and out, because there are lots of children who have been trafficked, who get lost from the refugee camps. So there are security protocols in place. So if there is somebody in the camp who is, committing crimes, or who's stealing, or who's, being abusive, or has committed any crime, then they will not be considered for resettlement. I cannot say what happens at the border because I don't know what the protocol is at the border. If there is somebody who's committed crimes and if they know that that person has committed crimes, would they let that person in? I am sorry, I do not have the answer to that question. And if anybody else knows it, please, if you could tell us, and I can try and find out what happens if they've committed crimes.
Okay, no problem. Thank you. There is a question from Afroz, at what stage are refugees screened for mental health? I understand they're screened for physical issues, ...
There is no screening for mental health, as far as I know. So what we are trying to do is, that's what we train. One of the things that we do is we train case managers from different agencies on how to identify refugees with mental health issues, on how to and when to take them to the emergency room, when to refer them for mental health treatment. So we do the training, but the refugees themselves are not screened for mental health. We are also trying at the Alliance to see at intake, to have a questionnaire, so like a PHQ-9 or a PHQ-2, or the refugee health screening questionnaire that's there that you can use. But at any official level, there is no mental health screening, unfortunately.
Okay, sure. Thank you. Next question from Monica. How long do refugees have to work in the US to be eligible for disability?
What do you mean? How long do they have to work?
Yes, that was just the question. I'm not sure if Monica's on still.
If they are disabled or?
Yeah, I was wondering if in the case that you mentioned that he wanted to be on disability, I know like any other person needs to have worked certain number of years to be
Yes.
eligible for disability. What is the requirement for refugees?
So I think the refugees have to have a green card to be eligible for disability, or they have to have, of course, they're all legal. All refugees are legally here. So I'm not sure if they have to work for a number of years to apply for disability, if the disability can be proved. Like for instance, this guy, if you see his MRI, you know for sure that this is why he's having these symptoms. Every time the weather gets really hot in Texas, he starts having these symptoms. So I don't think he has to work for any number of years to apply for disability. It's up to the judge to say, okay, I believe that this guy is disabled and he cannot work. If he works, his situation.
Oh, I see. Not disability. Like going disability, like as in insurance, but from SSI.
Like Social Security, you mean?
Yes. Okay.
Oh, so they have to be citizens. So usually when a refugee arrives, they have their papers, right? Legal papers, and within 5 years they can apply. Or within a year they get the green card, and within 5 years they can apply for citizenship.
Okay.
And I think you can only get SSI after you become a citizen.
Okay. Okay. Yeah. Thank you.
You're welcome.
Thank you. And there was one last question. Could you please define stateless persons again?
Oh, so stateless person is somebody who has no country. No country will accept them. You know, I think I need to go back to the formal definition, but somebody who like, so the Rohingya refugees, you know, they have been living in Myanmar, Burma for I don't know, many years, right? So Myanmar says you don't belong here. Bangladesh says you don't belong here. India says you don't belong here. So they do not belong to any country. So they are considered stateless.
Thank you.
Definition is in the.
Oh yeah, that's fine. And there's one last question because I will try to wrap up here. Are there any services that assist individuals that apply for a renewed visa, especially those that have a criminal record?
I'm sorry, can you repeat that, Sydney?
Are there any services that assist individuals who are applying for a renewed visa, especially those that have a criminal record?
And are you talking specifically about refugees?
This is Noah Garza's question. I'm not sure if he's still on and would like to clarify.
If you can clarify. And I don't understand the renewed visas, because when refugees come, they are not on a visa. They have legal papers and they get a green card within the first year. They're allowed to work. So they're not on a visa that it would expire. I'm sure he means.
Okay, can y'all hear me?
Yes.
Can y'all hear me, guys? Okay,
yes.
Good. Yeah, the question was really pertaining to just anyone who has, you know, they perhaps are of refugee status, or, you know, or perhaps an individual who has had a visa in the past and are unable to reapply due to the fact that they received some criminal charge, felony, misdemeanor, anything of the sort. But I did see someone mention YMCA. I do know that there's a stigmatism also, not stigmatism, stigma, a stigma towards those who are, you know, like those individuals are very hesitant to ask for help because they're really, they believe that you know, asking for help really shows, you know, like that means they got to come out of hiding per se.
Yeah, so I think I'm not sure if they will be considered refugees, but I think you're talking about. Are you talking about somebody who's been trafficked also, like somebody who's been through a lot and may have some criminal record?
Do you mean stigma?
Yeah, stigma, but
I said the wrong word. Yeah, but yes, the stigma is the right one.
stigma about having something in their record, like a criminal record.
Right, like you know, like if you're here in the States and you've been here for some time, and of course you're undocumented, and you know
Undocumented. So we're not. Sorry, I'm going to interrupt you. So we're not talking about refugees.
Mhm.
Undocumented migrants are very different from refugees.
Mhm.
So yeah, we can still talk about it, but I just want to make sure that the difference, because if you are a refugee brought in by United Nations High Commission of Refugees to the US or to other countries, you are not undocumented. You are documented, you have legal papers, you have everything. But if you're undocumented, if you've crossed the border and you're undocumented, yes, then definitely you have YMCA and Catholic Charities has a huge legal department, and they will help you apply for asylum. If you've been trafficked, they'll help you apply for the anti-human trafficking visa, U visa, T visa. If you're victim of domestic violence, they will help you apply for those visas, and they will not be deported.
Thank you so much for that information. Yeah, that's very helpful. It's
Also, I wanted to add this for you. If you know of anybody who is seeking asylum and who does not have a forensic evaluation, we do a forensic evaluation for free in the Human Rights and Asylum Clinic at Baylor College of Medicine, which is entirely run by the PHR, Physicians for Human Rights student group at Baylor. And we have wonderful volunteers, some of who are here in this presentation, who do evaluations and then submit it to the lawyer. So if you know of people who are seeking asylum, please reach out to me and I can forward the information to you.
absolutely, we'll definitely keep that in mind. Thank you so much.
So,
Perfect. Well, thank you so much, Dr. Banu, again, and everyone who's still on. I really appreciate this conversation and such great knowledge and information. I just put the link in the chat one last time, but again, if y'all could please complete that by 12 o'clock tomorrow, and I'll send out this recording. We'll send out the slides and everything tomorrow. And thank you all so much.
thank you so much. And I just saw a remark from one of my colleagues or from my team. We have to talk about climate refugees the next time. It's going to be,
yes.
The number is going to be, I don't know. I don't even know what the number is going to be, but it's, yeah.
Right.
Having me, Sydney, and it's been a pleasure. Thank you.
Of course, it's been a pleasure to host you as well. And thank you so much. We hope to see y'all soon at our next event. Thank you.
Bye.
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 Thank you.